Hi, my name is Claude Hemphill. I'm a neurointensivist at the University of California, San Francisco and Zuckerberg San Francisco General Hospital. And I'm going to talk about curing coma in the ICU. Hopefully, that's a little bit of an intriguing and provocative title. And so I want to take us through maybe where we are now and where we hopefully are going. I have one disclosure, but it's not relevant to this particular talk topic. Let's start with a case. A 56-year-old man with hypertension developed acute onset left hemiparesis and progressed quickly to coma. His Glasgow Coma Scale, the GCS, score was 6. And we ask, what is his family going to ask? Are they going to ask, is he going to be able to use his left hand in the future? Are they going to ask, is he going to be able to see? No, we all recognize what families ask is he going to live? And is he going to wake up? And what will his cognitive function be? And what can we do to improve his chances for survival and improve cognitive function? That's what they ask. That's what they want to know because the diagnosis, prognosis, and treatment of coma and disordered consciousness is really the central focus of neurocritical care across diseases. It's far and away the most important thing that we do trying to restore patients. So let's think about how we prognosticate coma in our current state. And those of you who take care of patients in the ICU with decreased level of consciousness or coma recognize this is what we use. We use phenotype. What's the neuro exam currently? We use demographics, age, comorbidities. Do they have other medical problems? We do a scan to look at the anatomy of a lesion. Where is the hematoma? How thick is the subarachnoid blood? How much midline shift there is in millimeters? And mathematical models have been developed based on this data, and some of you use these, like the impact score for traumatic brain injury, TBI, or the ICH score for intracerebral hemorrhage. But a concern we have is what's called the self-fulfilling prophecy. Question is, with the current way we do it, how good are we at prognosticating outcome in individual patients? And if several studies have looked at it prospectively in prospective prognostication, and if we use even a crude cut point of can they walk at 6 months or not, we're actually right about 80% of the time. So 4 out of 5 times we're right. Pretty good, huh? Or 1 out of 5 times we're wrong. So this concept of the self-fulfilling prophecy of poor outcome in neurocritical care, the idea is that care might be limited in patients. We might choose to limit care because they have a poor prognosis, presumed, in a patient that can and would recover. But we never get to see that because we allow them to pass away or limit their care. The idea has come about by saying that early do not resuscitate orders in intracerebral hemorrhage are associated with worsened outcome. And Alexei Turgeon found heterogeneity in Canadian trauma centers in traumatic brain injury that probably resulted in increased or at least heterogeneous mortality rates. This concept of the self-fulfilling prophecy is a pervasive theme in neurocritical care across all conditions. And we got to ask, why aren't we better than this? Probably because we're currently assessing what the patient looks like rather than assessing the true underlying mechanism of coma or impaired consciousness and the capacity of the brain to recover. But there are tools that are beginning to be used, and this is a study from now a decade ago from Stephen Loris and his group that looked at 54 patients well months, sometimes years after their TBI, stroke, meningitis, cardiac arrest. They were all in vegetative or minimally conscious states, and they assessed them with functional MRI, evaluating response to standardized motor imagery. And 5 of them, 9%, had awareness based on functional MRI. And I encourage you to watch Dr. Loris's talk as part of this, the rest of this meeting. Just last year, Jan Clausen at Columbia University in New York looked at detection of brain activation in unresponsive patients in the ICU using machine learning EEG to a standardized response to spoken motor commands, and found that 15% of this heterogeneous groups. Some had TBI, some had ICH, and so forth. 15% of them had brain activation by EEG that couldn't be seen on clinical exam. We're calling this cognitive motor dissociation. And the patients that had CMD, cognitive motor dissociation, were much more likely to have a favorable functional outcome. These are windows that we can't see using our current neurologic exam techniques. So where are we right now? Well, recovery of meaningful consciousness is usually the most important outcome for patients and families. And I'm going to say we probably come about as far as we can with prediction models based on patient exam, demographics, standard CT and MRI imaging. And this leads us to being wrong an unacceptably high amount of the time and enables the self-fulfilling prophecy. In the ICU, we do not use or even have treatments that are focused on mechanism of coma-impaired consciousness and its recovery. And there is a disconnection between the science and the clinical care that intensivists provide and our colleagues in the subacute environment and rehabilitation provide. So the Neurocritical Care Society last year started something called the Curing Coma campaign. And the idea is to bring together a community of scientists and providers and advocates to try to address this grand challenge and emphasize the continuum from acute care to recovery. ICU providers like myself need to be working with post-acute and rehabilitation recovery specialists and vice versa. It's part of my responsibility, even though I like mainly working in the ICU. So a paper was published just a couple of months ago that defined these 3 scientific pillars to get us started: endotyping, biomarkers, and proof of concept clinical trials. And I refer you to the paper for more details. But what do we mean by endotyping? What we mean is that patients may look clinically the same, Glasgow Coma Scale 6, impaired corneal reflexes, but there may be underlying different mechanisms of coma and the potential for recovery. Maybe what we're dealing with here is that the underlying nature of coma and the disorder of consciousness is more important than the specific disease itself. You know, we divide our treatments into TBI treatment, stroke treatment, but maybe we need to rethink this and think about a different classification of DOC, disorders of consciousness, that relates to structural damage or absence of it, and whether it may be amenable to replacement or bypass therapy. We tend to think about lesions. I can see where the hematoma is on the scan. It's in the basal ganglia on the right. But really what we're circuits. And the thalamocortical connections are key. So investigating using things like functional MRI and looking at the default mode network, that may be really more important than looking at a specific site of a lesion. And that's a shortcoming of our current approach. So we need better biomarkers, tools that allow us to assess coma and disordered consciousness in the ICU. And these might include currently available tools that need to be made user-friendly for the ICU, or novel neuroexams like the sniff test, a report that came out just a couple of months ago in coma patients. And these can be used already. There was a report in Critical Care Medicine, I believe this month, from a group in France that used fMRI, functional MRI, in the ICU on patients to look at network connectivity. And diffusion tensor imaging to look at the reticular activating system and intracerebral hemorrhage in the brainstem. These are possibilities, but they've got to be made more user-friendly. So here's the concept. It says personalized connectome mapping. One potential biomarker, not the only one, but we see a patient on the right with acute severe traumatic brain injury who's obviously got a lot fewer connections than the healthy control on the left, but some of those connections are intact. And that patient with severe TBI ended up being functionally independent at 6 months. So starting proof of concept clinical trials, the goal is really to improve consciousness and long-term cognitive function through new treatments that target coma mechanisms. It could be part of specific disease treatment for TBI, cardiac arrest, stroke, but maybe there's something independent as well. Amantadine's been studied and showed accelerated recovery when started 4 weeks post-TBI in severely impaired patients. It's proof of principle that this could work. And so there's a phase 1 and phase 2 clinical trials called STIMPACT, stimulant therapy targeted to individualize connectivity maps, like we saw in the prior slide, to promote reactivation of consciousness. The idea that we might be able to identify patients with the capacity to recover who still are in coma or impaired consciousness at the time we identify them and target them for specific interventions, in this case, IV methylphenidate. So the Cure in Coma campaign is off and running. It's not the only effort, it's one of many efforts, but the idea is to bring folks together. And so we have a National Institutes of Health symposium. The virtual symposium was held on September 9th and 10th. And there's going to be an in-person symposium on May the 3rd to focus on the next steps in science. The Come Together Research Survey is going on now, and you can go to the Cure in Coma website and figure out how to participate at your site. Common data elements are being developed through the National Institutes of Health, as they have been for other conditions, but we're developing them for coma. And we're going to have World Coma Day on March 22nd, an opportunity to report on the science, but also educate and bring together patients and their families as advocates to try to tackle this problem together. So, in conclusion, curing coma, that's a pretty bold and broad statement, but it's what we are about. So the question is, what can we do today? Well, we can do some things today. The first thing we can do is acknowledge uncertainty in prognostication and be humble. Provide aggressive care to our patients and give them a chance to recover. We need to recognize and avoid the self-fulfilling prophecy. But we do need to help families make decisions now in this context. We can't wait for the future. We have to make decisions now. And we want to incorporate guidelines in our patient care model. And I refer you to this guideline here that just came out earlier this year from the European Academy of Neurology on the diagnosis of coma and other disorders of consciousness. Daniel Conziella from Denmark was the lead author on this. And a number of the folks in this are part of the Cure in Coma campaign as we try to coordinate this. And then where do we need to go? We need to develop user-friendly biomarkers. We need to create new treatments. We need to further develop an organized ethics framework for coma care. And we need to create the community of provider scientists and patient advocates to do this together. Thank you very much.